So I was asked to give an overview of where we stand with long-acting anti-infective drugs. I'm going to try to do that, but I'm also going to try to preview what we're going to be doing over the next 2 days. So here are my disclosures. How many long-acting anti-infective products are approved today? Well, I went through and developed this list in preparation for this talk, and it's kind of a good news, bad news story. For HIV, we now have 4 approved long-acting drugs that we'll hear about today and tomorrow. Cabotegravir and rilpivirine, cabotegravir for prevention, the combination of the two for treatment. Lenacapavir for a treatment, the approval has been applied for and hopefully for prevention, and hopefully will be available beginning next month. And then ibolizumab for a treatment, a monoclonal antibody. We do have monoclonal antibodies also, though, for respiratory syncytial virus treatment and prevention. We had a monoclonal antibody for Clostridium difficile. Unfortunately, Merck discontinued its marketing because of low sales. And we had 3 monoclonal antibodies for COVID that received provisional approval from the Food and Drug Administration, but that provisional approval was withdrawn because those antibodies are no longer active against the strains of coronavirus that are circulating globally. It's important, though, to remember that long-acting anti-infectives aren't new. Historically, benzathine penicillin G was developed specifically because it was a long-acting way to deliver penicillin, albeit for a period of 2 to 3 weeks, which, when it was developed, sounded like a very long time. But besides the diseases and the organisms I just mentioned, what other conditions could benefit from long-acting injectables for treatment and prevention? Well, obviously, tuberculosis, hepatitis C and B viruses, and malaria. And we'll hear a little bit about all 4 of these conditions tomorrow. But keep in mind that other acute respiratory viruses, other bacterial infections, acute and chronic, probably other parasitic diseases, and even fungal diseases could benefit from the availability of long-acting injectables for treatment and or prevention. I want to give a shout out, though, to our colleagues in veterinary infectious diseases who've been ahead of the curve as compared to us. And this was a picture I took last week on my countertop to remind me that it was time to give my dogs their monthly heartworm, flea, and tick prevention. We're going to hear about a human analog of one of these drugs, moxidectin. We'll hear about long-acting delivery of ivermectin tomorrow. But long-acting anti-infectives have been a common part of the practice of veterinary medicine for much longer than they've been a common part of the practice of human clinical medicine. So I want to spend most of my talk on this question: what are the limits of duration for long-acting formulations? How long can we go? Well, a reminder that outside of infectious diseases, in hormonal contraception, 2 implants, etonogestrel and levonorgestrel, are approved for administration every 3 to 5 years. And this is a pharmacokinetic profile of these 2 drugs from clinical studies over 3 years. But the levonorgestrel implant is actually available for an administration once every 5 years for prevention of pregnancy. What makes these implants possible is that these are steroid hormones that are super potent, and they're also not water soluble. So those are 2 requirements for a very long-acting drug in a long-acting drug delivery formulation like an implant. And we're going to hear over the course of this meeting about strategies for identifying more potent anti-infectives and for turning water-soluble anti-infectives, which are released very rapidly from a depot, to hydrophobic, non-water-soluble drugs that would be released at a much slower rate from the depot and allow long-acting delivery. And those are really two important chemical features of long-acting anti-infectives that we'll be talking a lot more about. Now let's switch to drugs we have available today in our field. I'll start with cabotegravir. It was the first one of the first long-acting nanoformulations for HIV. And here's a figure from one of the first phase 1 studies of the cabotegravir nanoformulation, reminding us that a single intramuscular dose can produce detectable concentrations for over a year, in this case in seronegative volunteers. Although with the current formulation of cabotegravir, the drug sustains concentrations above the anti-HIV level for only 2 to 3 months, and the drug is only approved for administration every 8 weeks. But we'll hear about newer formulations of this drug that could be given once every 3 to 4 months. Perhaps not surprisingly to those of us who know something about this, long-acting injectable formulations in the HIV prevention space are dramatically more effective than daily oral pills. A lot of this relates to adherence, but here's a figure from the HPTN 084 study carried out in cisgender women. Several of the people in this room were investigators or part of that study. And you can see the red line is the cumulative incidence of HIV in participants on daily oral TDF and FTC, and the blue line are the cabotegravir recipients. A nearly 10-fold reduction in HIV incidence over the course of this study, with average treatment follow-up of about 3 years. A very remarkable result that's been outdone by this drug, lenacapavir, a drug that was specifically developed for its long-acting properties. And this is, again, a reminder from the first phase 1 study of lenacapavir that doses ranging from 30 to 450 milligrams produce measurable concentrations above the protein-adjusted EC50 for more than 12 weeks, and this drug is now approved at a dose of 927 milligrams to be given once every 6 months. But we learned 2 months ago a higher dose of lenacapavir given intramuscularly can be given once a year. So these are the pharmacokinetic profiles in the top of a single intramuscular injection of lenacapavir as compared to the every 6-month subcutaneous injection, showing that the intramuscular injection produced concentrations on average that were higher than that of the subcutaneous every 6-month dosing. And the trough concentrations with the yearly formulations were higher than the once every 6-month formulation, shown here with the 2 different once yearly formulations of lenacapavir in the green and the blue, formulations 1 and 2. Formulation 1 had 5% ethanol, formulation 2 had 10% ethanol. That was their major difference. Really, a really truly remarkable result, and the first anti-infective drug that puts us in the once a year category in human subjects. The injections of the once yearly drug were reasonably well tolerated. So this figure from an article published in The Lancet in March shows the results from formulation 1, the 5% alcohol, compared to formulation 2, the 10% alcohol. And the blue is no hurt after the injection, and the other colors range from hurts a little to hurts worst. Nobody, fortunately, had hurts worst, and not very many people in this study had hurts a whole lot. But you can see that certainly by 2 weeks after injection, there were no complaints at all about the side effects of this intramuscular injection. And if you pre-treated the injection site with ice, as shown in the bottom, you substantially reduced the perceived pain of the people receiving this shot. So it's possible to give a once yearly, in this case 5 milliliter intramuscular injection with very little pain if you pre-treat with ice. So lenacapavir formulations intended for once yearly injection are similar to the approved every 6-month formulation, but contain 5 or 10% ethanol. And the dose of lenacapavir for once yearly administration is substantially higher than the every 6-month dose. So 5,000 milligrams versus 927 milligrams. The injection volume is not the best, I would say. It's for the once yearly formulation, it's 2 5 milliliter intramuscular injections versus 2 1.5 milliliter subcutaneous injections for the approved every 6-month formulation. But because the trough concentrations for the once yearly formulation are about 3-fold higher than for the 6-month formulation at the end of a year, this, I think, suggests the possibility that you could use a reduced dose and a reduced injection volume and still reach your target concentrations for HIV prevention with this drug if you gave it once a year. So this is a first step. I think it's incredibly promising. I think it's proof of concept of where we can go with long-acting anti-infectives. Now, we don't need a once-a-year injection for every infectious disease, but it's important to keep in mind as we move through the next 2 days that current formulation science is now making this possible. Other once-yearly formulations in preclinical development are out there and also very exciting. And here's data that was presented at CROI in Denver in 2024 from Benson Adagwa and his colleagues at the University of Nebraska, showing the pharmacokinetic profile of a cabotegravir prodrug intended for ultra-long-acting delivery, and a single injection of this formulation produced concentrations in animals far above the protein-adjusted IC90 for more than a year. Benson is here at this meeting, and we're going to hear from him tomorrow about various prodrugging strategies for creating ultra-long-acting anti-infective drugs. Very exciting work. And a related prodrug has now been licensed to ViiV. Other long-acting drug delivery platforms in development, let's keep in mind that you don't just have to do subcutaneous and IM injection. You can do implants like for contraception, hydrogel injections, so-called bioerodible implants. We've learned about studies with vaginal rings, which could be given as infrequently as once every 3 months. Multi-purpose technologies incorporating, for example, hormonal contraceptives and anti-infectives into the same drug delivery platform. Microarray patches for transdermal delivery of long-acting formulations. Long-acting oral products like my dog's heartworm. Monoclonal antibodies, which have been modified chemically so that they have an extraordinarily long half-life and slow clearance, and other platforms in development that we're not going to have time to talk about. And here are images of some of these: microarray patches, vaginal rings, implants, and a transdermal drug delivery patch on my hand. So it's surprisingly well tolerated and fascinating new technologies for drug delivery. A reminder that monoclonal antibodies can be long-acting anti-infective drugs. This is pharmacokinetic data from a phase 1 study of an LS modified broadly neutralizing monoclonal antibody for HIV, VRC01, developed at the Vaccine Research Center at the National Institutes of Health. And we're going to hear about this and similar formulations tomorrow from my colleague Dan Kuritzkis. So keep in mind that this opens up a whole lot of avenues for treatment and prevention of infectious diseases, and there's proof of concept for this with several of the approved products I talked about at the beginning of my presentation. Finally, this is data from, this is actual data and modeled data from a long-acting HIV implant, in this case for islatravir, a nucleoside reverse transcriptase translocation inhibitor that was developed by Merck and is being developed as a short-acting oral version, but an implant of islatravir using the same drug delivery technology as developed for hormonal contraceptives, based on 12-week data from HIV seronegative volunteers, was projected to sustain concentrations of the active metabolite of this drug, the intracellular triphosphate, for more than a year, more than 12 months. So again, a second proof of concept of a long-acting anti-infective with the possibility of once yearly or even less frequent administration using implant technology. So that's my sweeping overview of where we are and what we have to look forward to today and tomorrow. As I said at the outset, although only a handful of long-acting anti-infective products and formulations are currently available, right now only for HIV and respiratory syncytial virus, many more are in clinical development, and many, I think perhaps most, infectious diseases could benefit from long-acting drug delivery technologies. For HIV prevention, injectable long-acting formulations are consistently superior in efficacy to daily oral combination pills, and we'll be hearing about this later in talks later today, and can now be given as infrequently as once a year. As technologies improve, I think it's likely that more products will come to market and additional new drugs will be targeted for their long-acting potential, their low water solubility, and their high potency. And finally, and most importantly, I think it's going to be a really exciting 2 days. I'm very much looking forward to being with you all and hearing about this great science, and I'm thrilled to be here with you in New Orleans. I'd like to acknowledge a bunch of people who've contributed to these data and other data we're going to be hearing about as the meeting progresses. These are the people who keep me going by paying for my research activities and many of our research activities. I will turn it over back to the chairs now. Thank you.